neki tehnikali, tle so še potrdila. Narejena so načeloma za vse, ki so se prijavili. Če za koga ni, mi prosim sporočite, ali danes, ali po mailu in bomo naredili in poslali. Druga stvar, tisti, ki niste dobili gradiv, ker jih ni bilo, ker je bilo samo za prijavljene, so zdaj gradiva na voljo v teh mapah, drugače še neka dodatna, ki jih je prispevala infekcijska klinika, kopije vseh slajdov so tudi na voljo. Tako, drugi del dopoldanskega dela strokovnega posveta začenjamo z izkušnjo iz tujine. Z nami je Rolf M Angelvedt, ja, z norveške partnerske organizacije HIV.si oziroma Gay and Lesbian Health Norway, bom tako govoril, ko bo lažje. And this part of the conference will be, as noted in the program, in English. Rolf has 20 years of experience of work on HIV/AIDS prevention, and the last 11 years he's leading, he's the director of the Gay and Lesbian Health Norway, and he will talk about how stigma, how they deal with stigma in Norway.
Thank you. Actually, my colleague should be here to talk about stigma. His name is Rolf M Angelvedt, and he's open HIV positive. He's an employee in our organizations. We actually have two almost open HIV positive employees in our organizations. And I think the most important thing that we do to struggle with stigma and self-stigma is to have to encourage HIV positive people to have their courage to open themselves for their family, for their friends, for their lovers, for their doctors, so that they can get the support that they need. And a huge challenge is, from my point of view, is the self-stigma. That in the same way that we see in the internalized homophobia, that there are discrimination out there. But as you all know, even Ireland now has a new LGBT law that same-sex couple can connect it. It's not connected?
No.
No?
It worked.
2 seconds ago?
It was perfect.
And the other one? No. Nothing? Should we change it? Or maybe we can put that in
You save it in the old format?
I think so.
It works.
It works?
Yes.
Okay. Then, yeah, I was talking about the internalized homophobia and the self-stigma among HIV positives. In Norway, we have actually two organizations that are run by HIV positive or people living with HIV. We have 3 or 4 organizations working with different LGBT issues. My organization, Gay and Lesbian Health Norway, is the only organization that doing MSM prevention work. So my speech will mainly be about the presentation of our work, our organization, and not so much about the stigma. I will comment it when I'm presenting our kind of work. Okay, and of course, a huge challenge has always been that LGBT people are invisible. You can't see my sexuality, you can't see my infection, you can't see my gonorrhea, you can't see my HIV, you can't see my syphilis. Maybe, sometimes you can see it. But in common, we can't see that. So we have to correct, we have to say who we are, we have to do that. Or sometimes we are tired of that, and we be a kind of stereotype LGBT. So you all know, oh, he's gay. And most of us aren't that kind of stereotypes. We are anonymous men and women living in the society as a minority. And that makes us vulnerable for ourselves and for discrimination and stigmatization. Okay. Let's see how this works. Okay. Helseutvalget is the Norwegian name for our organizations. It's established over 30 years ago by the LGBT organizations in Norway in 1983. When the political organizations saw that men was getting infected by a strange disease, that they were dying, they think that we have to establish a committee that worked with prevention work. And the two things we said in 1993 was use condom. That was before we know how HIV was transmitted. And we also said don't give blood to the blood banks. We were one of the first organizations in Europe that said actually that. And we're still saying that. We don't recommend MSM to give blood, and I will show you why. We also distinguish between health prevention work and political activity. We have different organizations that are doing that. So we are cooperating in different ways. In some countries we don't have so many different organizations, so you have to put all in one organization. But it's very important that you know how to reach out to your target groups. And for us, it's LGBT as a pronoun that you probably know what means: lesbian, gay, bisexual, and transgender. And there is all the others that don't have this identity put on themselves. And that's a bigger group than the LGBT group, I promise you. Also in Norway. We have all of Norway as our arena to work with our prevention projects. And maybe you don't know Norway so well, but Norway is a very long country. We are living approximately 5 million people in Norway. And that's a challenge. But the epicenter of the health problems among our target groups is in the capital, Oslo. As similar also, I think, in Ljubljana. Here is, I think in Norway, we don't actually know how many MSM and women who have sex with women who is out there, but we think that it's about 2 to 3% of the population. We think that also 60% of them are living in the capital or abroad. And we also, in every project, we have a holistic approach. That means that in every project we work with, we talk about drugs, we talk about alcohol, we talk about STIs, we talk about mental health issues. And we also have the age of the target groups for us is, in some projects we work on the internet with youngsters who are 13 years old, wondering who they are, have bad or good experience, need to speak to somebody, up to the oldest man that has been in our project is 85 years old when he come out for his family. So it's never too late to come out when you are belonging to our minority. Today we have 12 employees. 2 of them are heterosexual, 2 of them are HIV positive, and 2 of them are women. The rest of us are gay men who have sex with other men sometimes. And this is very important, and this is how our work have changed for the last 15, 16 years, is that every project that we have in our portfolio is based on research, and they are continuously evaluated. So we, in our organization, has, of my point of view, of course, have good evaluation data. And our method in all our projects is peer-to-peer. That means that heterosexuals can, of course, work in our organizations. Health personnel can also work in our organizations, but we mean that, or the research shows that it's easier to have women speaking to women, HIV positive speaking to HIV positive, youngsters speaking to other youngsters, older to olders, men to men. So that's our main method in every project that we do. And I will show you some examples about HIV testing in a little bit. We have been funded by the central government since 1985. We don't do any fundraising. We have all our money coming from the government, the health department in Norway, and we also have a huge amount of money from the local city of Oslo, who's the capital in Norway, who's supporting the rapid testing project that we have. And today we have approximately 1.2 million euros in our organizations, but it hasn't been that all the time. 10 years ago we had 500,000 euro, and it has been going up and down. And I know that that's a lot of money. That's a lot of money. We also have a partner. We have a partner also in Riga, in Latvia. They don't have any money at all. So we know that in Norway we are a rich country. We also, in this project that we are so glad to be a part of, the Norwegian government has contributed with a lot of money to do this kind of things. And we have a lot of supporting projects around in Europe and also in Eastern Europe. Okay, so we have, this is very traditional in a prevention community-based organizations. We do condoms distribution as we also had today. We do that in every arena that we know that men who have sex with men are participating. We do safer sex campaigns, as we have seen some examples of here today. We do counseling to empower men and women to take care of themselves. We do group works in different kinds of ways. Young youth coming out groups. We have groups for HIV positives. We have body supporting groups for HIV positive, where clinics are calling us if we have a gay man who is HIV positive to come and talk to a newly diagnosed HIV positive man, which is now thinking that everything is disappearing, my job, my family, my work, everything. And it's very supporting to have an HIV positive man who's looking well, taking his medicine and tackling his day-to-day life and he's taking care of himself. And for newly diagnosed MSM to see that that's possible, it's very important and has a huge impact. We do outreach work. We work in times of the day that we earlier didn't work. We work in the nights. We work at the saunas. We work at the clubs. We work when the bars are closed. We work with volunteers and with employees in very hard times of the night. And for 3 years now, we also have a project called Checkpunkt. In English, it's checkpoint. In Norwegian, it's checkpunkt, where we offer rapid testing for HIV and syphilis, delivered by peers, not medical personnel. It's trained peers that delivers, offer rapid testing and counseling. And all over Europe, also here, you have different kinds of services of dealing with HIV testing for MSM. This is not so common. We have struggled for 7 years with the Norwegian government, health department in Norway, to get money for this kind of project. To telling them that with this model, we reach more men, different men that doesn't use the ordinary health care system. So finally, after 7 years, we got the money for this project by our health minister. So it's a very prestige project for us. So when you called me 1.5 years ago, we were in the middle of, we had just started up this project. And when I heard that you also had testing facilities, it was very important for us to participate in the projects, also to learn about how you are doing it, because you are doing it different than us. So it's very important to exchange information about how we doing things the best way. We also have other partners. We are helping out a checkpoint in Riga in Latvia, which is also funded by a Norwegian grant. And we also are trying to establish a Russian project with MSM, which is not so easy, along with the Deutsche AIDS-Hilfe in Germany. And networking. It's a lot of work. Okay. As I said, we think that 2 to 3% of the population is belonging to the MSM and women who have sex with women group. In Norway, that would mean that we are approximately 60,000 MSM in Norway. Here it lives 2 million. That will mean how many? 10,000? 40? 30? We don't know. We know that they are out there. Of those 2 to 3% of the MSM population, we see that every year 60% are infected with HIV of those who are diagnosed each year. Because in Norway we also have imported cases. So if you take out those imported cases, we are having 60% of the incidence in Norway. We see also that alcohol and drugs, as the doctor mentioned earlier this morning, it's also a huge challenge in this population. We can see that lesbian, bisexual, and gays who drinks often or a lot is between 2 to 4 times greater than among the heterosexual, the majority population. We also smoke more, and we also are exposed more to discrimination, violence, and threats, and bullying. That's also a negative thing for well-being. Okay, I will just give you a short picture of how the HIV situation is in Norway. As you can see, here is from the early start. Here we got the tests, so we got a higher amount of diagnosis, and as you can see, here we are. It's still rising. This is a little bit older It's from 2011, but we see that it's still rising, and if we put them up every year up on each other, we see that the amount of people living with HIV today is so much higher than just for 10 years ago. And here I haven't controlled for deaths, because we have very poor data of who has died and who is living. So, but my suggestion is that it will be even, what do you call it in English? Higher, yeah. We see the same with the gonorrhea. MSM is the blue line here. This is a newer slide, and you can see also that it's rising and it's spreading also in the general population, because men who have sex with men also have sex with women. This is the syphilis statistics in Norway among MSM. It's rising. And it started 2 years after the heart treatment came. And HIV positive patients are also a huge, the patients have often syphilis as well. And that's very important to tackle. So, a little bit information about, now I will talk about our testing project. This is two men nervous for the rapid test. That's common, isn't it? And this is our website for rapid tests, and also here we have an anonymous chat function. That because every man we meet, they need to be anonymous about the results and testing, and it's very important to be discreet. And here we also have taken away everything that's connected to Helseutvalget, to the gay and lesbian health. You can't find it here. It's checkpoint. So it's not unusual that heterosexual men also come to test in these facilities. And that's very important about the internalized homophobia. If you're not a gay man, you won't use a service that is run by LGBT organizations. So it's very important also to think about those issues. But all of this is the testing is in the same facilities as our organizations. We have 2 doorbells, one for checkpoint and one for Helseutvalget. So we are using a method to reach out to these men. We also use social media as Facebook to announce for our project, but we also use Grindr. It's expensive, it's not so, but it's very effective to use, as you told me about how to use different kinds of platforms to communicate with our target groups. Here we have our health minister with national television and the Minister of Family Issues participating in our opening of these projects. So it's very supportive, and that's very important. And I will also say that one of the key issues for these projects is to establish good network with government, with clinics, with professionals who are working in this field. That's very important. And because there also, we imagine that we have thoughts about each other that it's very easy to get rid of when we're working together, because we all are doing that. Here is an example. This is Vegard. He's on his way to the sauna, where we have a little testing room, which we test 2 times a week. Here is the caravan Bob, who's driving around on the cruising scene to test MSM. And we are also using the INSTI test, the rapid test, who gives the result in 60 seconds. And we give the results on site, there and then, with pre and post counseling. And for somebody, this is challenging. But it has run for 3 years now, and it has went really well. And I think we have been testing approximately 22 HIV positive gay men in this project so far. Here you can see, here is the biggest discotheque in Oslo, where we are having our van, and we are testing in this caravan, like this. We also rent hotel rooms. This is in Bergen, a town where there lives 300,000 people, where we have rented rooms in cooperation with this hotel, and we put up signs where they can have the test, and men who have sex with men comes to this hotel and take a test. And here we have had positive tests. So we offer gay and bisexual men and other men who have sex with men safer sex conversations, which is the main goal for this project, to try to get men who have a risky behavior to know what they are doing. And we offer them rapid tests for HIV and syphilis in a non-clinical settings. And that's very important to reach those men. There's non-clinical. That doesn't mean that it doesn't work doctors in these projects, because we have head of chief in a big hospital who's in medical charge of these projects. We have nurses, we have different kinds of people with different backgrounds working in these projects. So that's very important. And all the men that we are testing, they are referred to the hospital at once. We just call the clinics, and we have a good cooperation with 7 hospitals in Norway that we can call, and they can come in at the same day. And they are taken good care of. And it's very important for me to underline that this is not instead of the clinics. This project is not instead of other places where you can take an HIV test. It's not a project that's trying to undermine the good work that health professionals are doing. This is a project that's reach out to different kinds of target groups they wouldn't have come anyway. So these projects are aimed to reach out to those men that wouldn't come to take a test. And in our project, 1 of 3 have never had an HIV test before, which is very high. We also see that 1 in 3 is from the migrant MSM population, which doesn't use the health service at all, almost. And we didn't believe that in the first, that we should reach out to those groups, but we actually do. So we are very proud of that. And in the conversations we have with our guests, we don't call them users or clients, we call them guests. They are guests in our project. And that's also a way to try to make an HIV test not so dramatical, making it easier and not so scary, where we use those kind of words. And we also, in our project, uncover people with drug problems, with mental health issues, with other issues and it's very important for us to have the possibility to help them to reach out to other help services. And the prevalence so far has been up to 1.9%, and now I think it's 1% because we have very much focus on volume. This year we will test 1,500 MSM, and the biggest clinic in Oslo had tested 2,500 last year. So we are reaching out to a lot of men who have sex with men out there. And here we have Axel, and with some volunteer. Last weekend we had a Pride in Bergen. It's on the west coast, and I know that you're having Pride here this week. And I want to share this with you because this is our Prime Minister walking in the front of the parade in Bergen. It warms an old gay heart to have our own Prime Minister working as a Prime Minister, taking her day off to go with gays and lesbians in Bergen to show her support of the cause. And of course it's not too bad to be a gay in Norway, but despite of that, we see those high numbers of HIV, we see high numbers in other STIs, and we also see different other challenges about health of LGBT people in Norway. But I used to say that it's approximately 10% of us who are striving to get a better life. 90% of us are managing to having a good life. That's very important to also have in mind. And about the stigma discussion, I want to say that for us it's also a very important message in our work that we encourage MSM and also women who have sex with women to be open about their sexual orientations as often they can. And about their identity, what is today you can have different identities, and also about HIV diagnosis. That doesn't mean that you have to go to the newspaper or on the television, as Walter do in Norway. He participates in the national television twice a year. But that it's very important to be yourself, to be having good life. It's about feeling that you are supported in your among your friends and families. Okay, so here's some final comments. We all know that testing is very important to get them to come to the clinics to get treated, so they get low viral load, so they don't infect other sexual partners. We see also that testing messages is very important to get out there because we have very poor data about how many people who are actually getting tested. But nowadays we get more and more representative data from America, England, who sees that the testing activity is actually really low. We thought, because we have done several community surveys in our own community where we have questionnaires, and they are asked, have you ever taken an HIV test? Of course. 70-80% of them saying, yes, I've been testing. And then this is very good. We can't get any higher than 80% testing. But we should be having testing activity up to 90% to tackle this infection disease. So when we see that in some countries the testing among MSM is as low as 15 to 25%, we have to think again and to get the testing activity up. We also see after the introduction of and the treatment, the condom use has going down very much. So we have a very big challenge to raise the condom message to our population, because we can't treat us out of this epidemic. And then we see that this kind of different kinds of low threshold, some anonymous, some not anonymous rapid testing service for MSM will facilitate safer sex conversations, contribute to disclosure, and about testing and risk behavior for a group of men that do not make use of existing services. And that's a very important function for these services, because they can act as a guide to various health services. That will be my final comment. And here's the condom in action.
Thank you, Rolf,
Thank you.
for the presentation. Maybe you have some questions, any comments? Yes.
Irina Klaus, National Institute of Public Health, epidemiologist. Thank you very much for this very informative presentation. It's very good to know that you are working in such a well-resourced country, and you have the privilege of even having such an outstanding support of your Prime Minister. So this is very good to know, but a tiny question. You were saying as far as HIV testing services in the community are concerned, you were saying that you're providing it especially for those who would not come to healthcare settings, nor conventional settings. You were saying that you are in very good contact with 6 hospitals. People are referred within the same day. Do you manage maybe to follow up the success of your referrals for confirmatory testing or supplementary testing and the entry into healthcare?
Yeah, all of the men who have been tested positive have been to the hospital, have taken a new test, and everybody has gotten confirmed HIV positive diagnosed. And then the hospital take over the treatment and care.
So you have 100% success in terms of referral?
Yeah.
Because you were saying these are the people who would not go to services otherwise.
Because we are following them.
Yeah.
So you have very good linkage and retention.
Yeah.
Is it general in Norway, this attitude? So in your program you are running, linkage is 100%.
I can't.
And retention is also very good. Immigrants, as you mentioned,
Yeah.
no big problem.
There has been some struggling to get people to come to the. After we have followed them, they haven't come back. So we have helped out in 1 or 2 cases about helping people coming back. And those were immigrants. So the connection that, of course, we have, we can't, what do you say, taushetsplikt? We have signed, Yes, we have the signed confidentiality, so we can't tell about everything. And this is supposed to be an anonymous testing facility. So if they choose not to go to treatment, we can't force. But many of those who are vulnerable or are getting a positive test are very open for good suggestions that we're making a plan, that we can take a phone call, we can help you to get in treatment. And everybody has said yes to that. So that has been very important. But I'm not sure if they felt ill or making sick. It's not so common to take an HIV test when they are coming to a hospital. So we have a lot of stories about late testers who has actually got AIDS symptoms, and some of them also die. So it's very important for us to test them very early.
So the percentage of CD4s below 350, what would be the percentage, if you know this figure?
I don't know those figures, and the clinics don't cooperate so much, so they don't have that quality data on their patients. So, but they are working on that, and also now as you probably know, the START study has been stopped because of the good results. So in Norway now they have changed the policies to start treatment at once.
We mentioned it in the afternoon session. We mentioned
okay,
start study.
Rolf, you followed our morning session, and how would you estimate the Norwegian situation when it comes to attitude to LGBT patients or MSM patients in the broader health system? What is the level of issues that maybe Norway is?
We were participating in the EMIS, the European Internet MSM study, which has 180,000 MSM in the whole Europe participating, and we saw that it's the HIV positive men were discriminated in one area, and that was the health system. And probably an answer to that, or a partly answer to that, is that in the healthcare system they have to be open about their HIV diagnosis. In the rest of the society they can be in the closet. But I think that healthcare workers are generally positive and trying to do their best when they're approaching HIV positive clients or to LGBT people. But they sometimes spell the word wrong, or they do things wrong, or they have presumptions about how two men are having sex and saying wrong things. So we have that, but we don't have good data on that actually. But we see that there's not so many HIV positive men who are open about their HIV status. So that's an indicator that it's not so easy, even in Norway, to be open about that. So we were sitting here listening to you, and we got a message on Facebook that one of our friends came out as an HIV positive on Facebook today. So it's much easier though to come out and earlier. You can say it on Grindr, you can say it in social media, you can be open, but not flagging that you're HIV positive, but you can be in small ways open towards your sex partners or family or friends on a social network maybe. And I think it's a very important issue to work with. It's not something you can fix like that. It has to take some time. But I also think that in the Norwegian health system, HIV has always been treated very special. It has been very special rules about how we deal with HIV. So I will participate for your discussion about how to make a new strategy to tackle that. And I think that we need to normalize HIV diagnosis also in the system to see results among the HIV positives and HIV negatives, how we react when we got to know that somebody is having the infection.
Okay, thank you, Rolf. And now we proceed